speakers, Dr. Brower, who you're probably familiar with, as well as Dr. Ablin, who's been here even longer than Dr. Brower has, and they're going to have kind of related topics. Dr. Brower is going to be talking about how to manage some of the more difficult patellar luxation cases that you might see. You may not be doing a lot of distal femoral osteotomies, but you'll be able to recognize the ones that you don't want to do anyway. I know a lot of you do surgery here, and you do a great job. I mean, most of the stuff we see that comes in from the outside is good work, and I'm hoping that we can continue to get you enough information on the CEs that you can continue to do the great work, because it's important that we have a really good, well-trained, well-informed general practitioner, primary care practitioners out there, because that's what saves the day in most cases. We do appreciate all the help that you guys give us as well, not just sending in the cases, but doing some of the follow-up for us and that sort of thing. I know some of you like to do that, some of you don't. It depends on the case, I understand, but for the work that you do, we do appreciate that very, very much. I have a few announcements here first that I'd like to cover. I just want to remind everybody about the bereavement group. It's 2 times a month. We've been doing bereavement for clients and non-clients of ours for, well, since we've been open here anyway. And I just want to emphasize that bereavement is not just for our clients or our mutual clients, but for any client. So if you have a client that's lost a pet and you feel like that they would be good candidates, might welcome the opportunity to participate in our bereavement group, please send them. They don't have to have been here before. It's a service. It doesn't cost anything. We do have a licensed practicing psychologist that runs the program for us, and everybody is invited. So please don't hesitate to send them. Again, they don't have to be clients of ours at all. If they think they might want to come, please encourage them to do so. Let's see. I can make the announcement for, I guess, June. Continuing ed is going to be Dr. Mensack. He's going to be talking about the initial management of head trauma, I think. So Dr. Mensack in June. Couple other things, I guess. Dr. Villamil is a medical oncologist. Some of you are familiar with him. He travels to a few different places on the East Coast here. Dr. Villamil is a good medical oncologist. He used to work for Dr. Correa, and he kind of got off on his own. He was working in Orlando for a while. He comes to us on Fridays, so if you have an oncology case, a medical oncology case that you would like him to take a look at, he is here on Fridays. He will probably be adding another day starting in June or July, so he'll probably start doing Tuesdays and Fridays. So if that's going to be helpful for you for some of your clients, please don't hesitate to give Dr. Villamil a call, or you can call our front desk. We can also schedule appointments for him as well. So, but he's a good guy. For those of you that have worked with him, you know, he's a real quality guy, does some great work, takes really good care of the clients. We've been really happy with his work, and we're thrilled to have him here an extra day a week starting in about a month or so. Let's see, what else have I got? All right, so tonight we got Dr. Brower and Dr. Ablin. Even though you probably know Dr. Brower, just a quick recap of where he's from. He is from Manhattan, and we like him anyway. But he went to college in Minnesota. I figured it's probably because New York was not cold enough for him, so he decided to go to Minnesota to go to college. But he then came back east and did his DVM at Tufts. After that, he traveled around a bit to California and Dallas to do his internships, and then finished up his residency on Long Island. So Dr. Brower has been working with us since last year. We've been very privileged to have an excellent surgeon on our staff. For those of you that have worked with him, and certainly the clients that have worked with him that have been your clients, I think you'll appreciate the work that he does here. He's going to be talking about managing those difficult MPL cases, as I mentioned, and give you some idea of those cases that maybe the ones you maybe don't want to touch and maybe just really want to send to him. That'll be followed by Dr. Ablin. As most of you probably know, we're doing physical therapy here now. We started the program relatively slowly. We wanted to try to get our systems in place and not really be too overwhelmed. We're continuing to expand that program. We're probably going to be expanding that to 5 days a week. It essentially does 5 days a week now, but will probably be more thoroughly engrossed in a 5-day or 5+ day a week program here coming up. Dr. Ablin can do laser therapy, acupuncture. She does underwater treadmill, and what's that other stuff you do? Tens, what else? They have a gym, yeah. So anyway, we can do most of the things that really need to be taken care of, and we're wanting to dovetail her talk with Dr. Brower's, since a lot of Dr. Brower's patients that are going to undergo this kind of a procedure would probably be very well served with some rehabilitation. So Dr. Ablin will follow up under Dr. Brower. Thank you for your patience. Without any further ado, Dr. Brower.
Hello, how's the volume? Good? This is great. Thank you, Dr. Roy. As Dr. Roy mentioned, the scope of today's talk will be a lot on the high-grade MPLs, those that are more complex and that have to do with limb deformities, but also a good overview of those basic ones that we see and how we kind of make that decision as far as doing corrective ostectomies versus traditional procedures to correct them. So again, we'll go through kind of the epidemiology and the pathophys of MPLs, specifically the quadriceps patellar mechanism, which will really dictate what treatments are most suitable for each case, going through the diagnosis and surgical planning, especially that has to do with DFOs or distal femoral osteotomies, and then finally going through the postoperative care, prognosis, and complications with these procedures. So MPLs, as you all know, it's one of the most common congenital abnormalities that we see and cause of lameness in dogs. Can occur in any breed at any age, although there is a little bit difference between smaller and larger breed in how they present. In the smaller breeds, they're bilateral in at least half the cases, which is different than larger breeds, and the clinical signs can vary quite a bit depending on the grade and how much arthritis is present. In the grade 1, as you can see up here, there isn't much skeletal deformity at all, and it's usually an incidental finding on exam. There's rarely any clinical signs present. The grade 2s, which we see more commonly, may have a little bit of crepitus on range of motion. The patella can be luxated manually, but for the most part stays within the trochlear groove. But they can progress. Typically, the clients may see an intermittent skipping that is transient and doesn't cause any pain, but they can lead to more persistent lameness as arthritis develops, or it goes into a grade 3 when you have more erosion of that medial trochlear ridge. And then the grade 3s, you're going to have more of a limb deformity in the tibia, specifically internal rotation. The patella sits for the most part outside of the trochlear groove, although it can be manually replaced. These are cases where you may feel a very shallow trochlear groove as well on exam, and are typically more clinical. And the grade 4s have the most severe skeletal deformities present. Clinically, they're more affected. Bilateral cases, they may walk with their limb kind of rigid, semi-flexed, internally rotated, like this picture here in the bottom right. And then large breeds are a little bit different because they don't present as the small breeds do. They're typically younger at presentation, on average around 2 years, based on the studies. They're also usually unilateral, which is different than the smaller breeds. And they typically have femoral and tibial deformities present. The large breeds are also more inclined to get traumatic MPLs, which we rarely see, and it's more congruent with how people present with luxating patellas, where their medial femoral patellar ligament ruptures. Same thing in the large breed traumatic MPLs, except it's the lateral ligament that ruptures. So the pathophysiology is important to know because that'll kind of dictate the best, most appropriate treatments for each individual case. And it isn't definitively proven, but it's thought that there are two main skeletal abnormalities that these dogs are born with, and that's coxa or a decreased incline to the femoral neck and head, as well as a decreased angle of anteversion, which is just external torsion of the femur. And those initial abnormalities lead to the other skeletal abnormalities that kind of present later. But what's thought is that causes an abnormal medial tension on that extensor mechanism, which causes uneven pressure on the distal femoral physis, and you get diminished growth medially and overgrowth laterally, which just exacerbates the medial luxation of the patella. And then you can have compensatory growth with the tibia. Those dogs, which are most often seen, that are bow-legged, where there's no real compensation in the tibia, that's genu varum. And then a lot will look normal grossly. If you look at them from behind, they'll have a straight limb. And that's usually because their tibia has a valgus. And if you take an x-ray, they'll have a sigmoid skeletal picture, but and it'll look normal grossly, although there's two limb deformities present. So the quadriceps patellar mechanism, that's the key to kind of both understanding MPLs and treating them and knowing which ones need which treatments. It includes the quadriceps muscles, all muscles of the quadriceps group, going down to the quadriceps tendon, which attaches to the patella, and then the patella tendon or ligament, which then attaches to the tibial tuberosity. So that has to be in line with the underlying femoral shaft and the proximal tibia in order to function appropriately. So when anything kind of deviates from that is when problems arise. I like this picture because it kind of shows the many different abnormalities that can be present with MPL, starting with coxa vara proximally, going to a distal femoral varus, and hypoplasia of the medial femoral condyle, internal rotation of the tibia, a shallow trochlear groove. You can have tibial valgus, again, as well as internal rotation, and then internal rotation of the foot in the frontal plane. So there can be all these abnormalities present or just one or two, and that kind of will determine how best to centralize the patella. So to go through this real quick, diagnosis is pretty straightforward. It's one made on physical exam. I like to do them standing if I can for the more calm patients, so I can assess symmetry. I can assess how their limb looks grossly, as far as if there are any deformities present or not. And then luxation, we want to both grade it and then characterize it as far as medial versus lateral, because a lot of them will be lateral too, although obviously not as common as medial. And then to rule out concurrent cruciate disease. So that's how they most often present, is a dog that has this history of MPLs for a long time that isn't really clinical, and all of a sudden they're suddenly lame. And it could be a progression of arthritis or erosion of that ridge, and suddenly it's a grade 3 instead of a grade 2. But more often than not, it's because there's some component of cruciate disease. They either partially or completely tore it. And then imaging is the next step. Ideally to document luxation, although a lot of times if it's a spontaneous luxation like you have in your grade 2s, it'll appear central on the femur. But you also want to look for osteoarthritis, because if it's an MPL that isn't really clinical that you're monitoring, you want to evaluate to see if there's progressive osteoarthritis in that stifle, which may dictate whether or not you surgically treat them or not. And then also to evaluate for any femoral or tibial deformities that are present. In this dog, there's a medial displacement of the tibial tuberosity there, and some tibial valgus. So that's important to see on your VD view, and you can center in on that. In general, when you do have these complex cases, you want to look at each limb individually. So an initial VD radiograph is definitely appropriate. And then after that, to take single views of the femur and then the stifle and tibia if there's an abnormality present. And then the most questions that we get regarding MPLs are whether or not it's something that needs to be surgically treated or not. And sometimes the answer is straightforward. For grade 1 with no clinical signs, conservative management's indicated. Grades 3 and 4, early surgical intervention is recommended, but the majority are grade 2. And there are those that are sort of subclinical with very mild or infrequent signs, which can probably be watched and monitored. But a lot of them will have clinical signs that are either progressive or that kind of just pop up on their own. And what's considered significant, kind of that varies between clinician. And for me, the criteria I use is significant episodes of lameness that are kind of persistent for at least a couple of weeks, or several episodes of severe lameness during normal activity in a short period of time, like a month. Those cases, even if it is a grade 2 and it sits in the groove for the most part, we'd recommend stabilizing before it becomes a grade 3 or before it causes a cruciate rupture. And that's sort of not proven but theorized as well, is that when you do have a chronically luxating patella, that's going to put internal rotation strain on the ACL, which is why we do see a lot of concurrent cruciate disease in these patients, especially large dogs, where it can be 40 to 50%. So treatment, the goals are several: to align the extensor mechanism if there are abnormalities present, and that can be with corrective ostectomies or tibial tuberosity transpositions, to deepen the trochlear groove if that is shallow, as in most small breeds, if needed, and then to create a stable femoropatellar articulation, and that's with deepening of the groove and your soft tissue reconstructive procedures, your lateral imbrication and medial release. So it really is a case-by-case basis, and we have these procedures in our toolbox that we kind of implement on an as-needed basis. In general, the trochlear groove is addressed first, so that's when we'll do our wedge or block recession. The extensor mechanism is aligned second, and then third, we balance the soft tissue pull on the patella. With the exception of a femoral ostectomy, a lot of times we'll do that before these other procedures. So to quickly go through the trochleoplasty options, deepening of the groove, most often we'll do a wedge or block recession, and that's typically with what you're most comfortable with. Both those techniques preserve the hyaline cartilage that articulates with the patella, so they are preferred. The block recession theoretically preserves more of that hyaline cartilage and has a more stable articulation with the patella, especially proximally. Probably not a huge difference, though. Achondroplasty, if dogs are very young, is an option, but usually we don't see those when they're that young. And then sulcoplasties or abrasion trochleoplasties aren't really done anymore, recommended, because it does remove all of the articular cartilage that the patella glides over. It relies on fibrocartilage forming afterwards, but obviously that's suboptimal. And if you scope these dogs later, those that have had sulcoplasty do have more arthritis in a shorter amount of time. And then tibial tuberosity transpositions are a very important part of aligning that extensor mechanism. One of the most common reasons that there's failure of MPLs or recurrence of MPLs after surgery is failure to do this procedure. Sometimes you'll make that call on x-rays if you have a really good craniocaudal x-ray and can align the hip, stifle, and hock, and you'll see that medial displacement. But a lot of times you'll also see that in surgery. These dogs are usually in dorsal recumbency, so you want to align the hip and the hock and the stifle. And if that patellar tendon deviates medially to the tibial tuberosity, then a transposition is indicated. And ideally, especially for bigger patients, you'll do pin and tension band repair. At times with small dogs, I just do a couple of pins. Have not had an issue. There's a technique using a headless compression screw as well, but they heal predictably in about 6 to 8 weeks. See, and then lastly, the soft tissue reconstructive techniques, which are done last. So after you do your deepening and your tibial tuberosity transposition, again, you palpate and you look to see how the patella is tracking when you flex and extend the stifle. And if there's any pull on it medially, first we would do a medial release where we cut the retinaculum or the capsule for really fibrotic cases. Usually that's needed in the really chronic ones, which are usually the small breeds that have been dealing with this for a long time and now have just progressive arthritis and they're no longer comfortable. And you can extend it up proximally to the insertion of the sartorius or the vastus medialis. And then lastly is your imbrication, and you can do that with the biceps fascia or the capsule. I usually don't like to do that with the capsule if it truly is constricted or is lax on that side. Then I'll do a little synovectomy or capsulectomy, and then oppose that normally, and then imbricate the biceps, and that's usually appropriate. So those are all the traditional techniques that have been used, the grade 2s and maybe mild grade 3s or small grade 3 techniques that are used, which have had a reluxation rate of between 8 and 48% in the studies, and most recently 8%. The 48% is those cases where only soft tissue reconstruction is done. Doing your skeletal reconstruction, we get it down to 8, which it's good, but not perfect, and that sort of has led to the development of looking at limb deformities specifically as a component of the pathophysiology of MPLs. Yes. Yeah, these are ones that reluxate on the same side. Mm-hmm. But that is a good point, because you can over-imbricate and you can over-transpose, and you can end up with a laterally luxating patella when you intended to treat an MPL. No, I don't. In all these studies, the reluxation rate was all on the same side. So that kind of started this investigation into limb deformities, because these complications would occur, and specifically in those high-grade MPLs and in large breeds. And in people, doing distal femoral ostectomies is part of the treatment protocol for those with chronically luxating or dislocating patellas and anterior knee pain. If they're young, they'll usually just put a little staple on the physis, and if they're older, they'll actually do a closing wedge ostectomy. So it kind of highlights the need to address all the underlying conditions in each specific case. So specifically for MPLs, femoral varus has been implicated in both large and small breeds as contributing and as a cause for postoperative complications. Initially, we looked at it in larger breeds, where we saw cohorts of labs that had MPLs and those with cruciates, and those with MPLs had a much higher femoral varus angle or degree of curving of their femur. That has now extended to small breeds, where we see there's a study with Pomeranians. Grades 1 and 2 will have a normal femoral varus angle, or closer to normal, than those with grade 3 or 4, where we see more of the complications after surgery. And we measure it with what's called the ALDFA, or anatomic lateral distal femoral angle. Previously, the femoral varus angle was used as just kind of another way of quantifying how much that femur is curved. So usually your suspicion for a limb deformity is based on physical exam, but then you quantify it based on imaging. So a lot of times these dogs will have that genu varum, or bow-legged stance, although, kind of as I mentioned before, they can have some compensatory tibial changes, so they'll look grossly normal until you take x-rays and you see that there's an abnormality there. So again, the point is to align the quadriceps mechanism. In this dog, which is a lab with a unilateral deformity, the quadriceps, which extends from the rectus femoris attachment, just on the cranial acetabulum, down to the trochlear groove and the tibial tuberosity, that should ideally be a pretty straight line. And in those where there's a femoral varus deformity, it curves there, and that's going to put medial tension on the patella and contribute to luxation or complication after surgery. So imaging is the first step in diagnosing and coming up with a surgical plan, and it can be very difficult because you do want a very straight image, because artifact can lead you to a falsely elevated femoral varus. There are criteria used to determine whether or not an image is of sufficient quality, and those are listed here. Fibella bisected by the cortices and parallel lines with intercondylar notch. But that can be difficult. I already mentioned one way is rather than taking a VD pelvis, doing one limb at a time is important. A lot of these dogs will have some concurrent hip issues too, or you're not able to extend that hip appropriately. So if you do have a radiography where you can move the beam, you can do that so that the plate is parallel to the beam. You can sit the dog up in a trough and then take it that way, or use a horizontal beam technique. And they've all been validated in studies as being appropriate for measuring varus. And this kind of shows why you can have such bad artifacts. So the femur normally has a procurvatum. So if you can imagine that femur being a little externally rotated, that on a 2D image is going to look like femoral varus. It's going to be curving in. So making sure that you're not rotated at all by following those criteria is important. Or you can do CT. And now, especially where we don't need general anesthesia, but just heavy sedation to get really good CT images, this is a lot easier, especially when you're going to be making corrective ostectomies. It allows for 3D reconstruction, which is what I use to measure femoral varus, as well as other deformities. You can look at individual slices. You don't have to be as precise with the imaging. And it allows for measurement of anteversion. There are studies that show CT as being more accurate when we compare it to anatomic specimens than just X-ray. Yeah. I think kind of following these criteria is important in evaluating the image when you take it to make sure that that's occurring. But heavy sedation is critical, or anesthesia, which is why I like CT also, because they usually end up being under for the same amount of time with the same amount of sedation. and you get better images with the CT. But a lot of us have kind of radiology tables where we can't move the beam or do a horizontal technique. So this middle image is probably going to be what you're doing mostly to get the most accurate images. And then doing one leg at a time will make things a whole lot easier. And then, yeah, I was going to say with CT, it's also a lot easier to measure anteversion. So that was one of those skeletal abnormalities that is probably present at birth that contributes to MPLs. It's difficult because it's hard to measure radiographically, and not a lot of people do. So we don't have data on what is exactly normal and what's not, because there are breed differences in every limb measurement. But what I did, what I was trained to do, is to, with CT, typically measure if there is a big femoral torsion present. We measure the anteversion angle by taking a line that parallels the femoral condyles and then adjoining it to a line that goes from the femoral head through the neck to the femur, and that measurement is your anteversion angle. And 27 is considered normal. If it's less than 27, it means there's an external rotation, which is probably deviating your quadriceps patellar mechanism medially and contributing to MPL. So this is, again, kind of what I mentioned, or speaks to the point of there being a case-by-case basis. If a dog has a femoral anteversion angle that's only 5 degrees off, but has a very shallow groove and a medially displaced tibial tuberosity, those are probably the factors that are most important correcting, and not making a corrective osteotomy in the femur. So just to quickly go through how we measure the ALDFA and why the true craniocaudal view is important. We first draw our anatomic axis, which is a line that bisects the femur. The femur has a normal amount of varus in it in any way, so we start with proximally or a point that's halfway up the diaphysis, and then one that's a third, and then a line intersecting that. And then that intersects with our distal joint reference line, which is just a line that measures that just goes across the femoral condyles and signifies the stifle joint. And then that angle there is your ALDFA. The AMDFA is on the other side, and that's also measured. So that kind of quantifies varus and how much is there. And like I said, there is a normal amount of varus in most dogs, and we have some values for breeds. Labs, Shepherds, and Rotties, they're generally between 94 and 98. So before we had those values, we initially, and this was in the early 2000s, shot for about 90 to 95. Now what we do is kind of measure it based on the breed reference if we have it, and if not, look at the other leg if it's normal, and try and aim for a corrective ostectomy that is similar to that. Where we make the ostectomy is based on the cora, or the center of rotation angle. Again, drawing our femoral anatomic axis, our proximal femoral anatomic axis, and then our distal femoral anatomic axis that is just a perpendicular line that comes from the distal joint reference line. This is kind of what I mentioned before as being what's changed. In the past, we used a perpendicular line. Now we'll use a line that mimics the ALDFA of a normal dog, and that may be more clear on the next set of images. So this is a lab that we did surgery on that shows our preoperative planning, and we got X-rays and a CT recon of the femur there. So again, same way measuring the ALDFA with a line that bisects the distal joint reference line. And then our cora we see is at the distal diaphysis and that angle is going to be the angle that we correct. So we use an ALDFA of 97 degrees because that's the breed normal for Labradors. Coming up, we see that this intersection here is we're going to want to make our corrective ostectomy, and that 14-degree angle is what we're going to correct. So ideally, we end up with a straight limb and a straight quadriceps mechanism. So to kind of reiterate how we treat that is at that cora, performing a corrective closed wedge ostectomy that is as wide as needed to correct the angular deformity. We could also do an open wedge osteotomy, which is technically easier, rather than making taking out a wedge with two ostectomies or two osteotomies. We just do one, and you can fill in the bone with graft, but it's not as stable. With a closing wedge ostectomy, you have bone-bone apposition and a good repair that heals pretty quickly. So that's what's typically done, and then also addressing the other issues that may be involved, the other corrective techniques that I discussed, as well as stabilizing the stifle if there's concurrent cruciate disease. So here's some pictures of just kind of showing what it looks like. In the majority of cases that I've done, we've used DCPs or LC-DCPs on the lateral aspect of the distal stifle to stabilize it. We use the TPLO jig cranially in order to make sure we don't introduce any deformity in the frontal plane, or if there is torsion there, to correct it with the jig. Now they make these upside down TPLO plates. They kind of look like these hockey stick plates that are made so that you can get three screws in that distal femoral diaphysis pretty easily, because that's usually the limiting factor, especially when you have to deepen the groove, is those screws can interfere with where you're making your cut. More gross pictures of the wedge ostectomy being performed. In this case, we already did a wedge recession. The jig is in place cranially. After measuring with calipers and a goniometer, we have our wedge, which is then opposed, and then a DFO plate placed laterally. And then a lot of these, like I said, will have an ACL injury, so we'll do TPLOs or TTAs concurrently, but they'll also have a tibial valgus deformity. In the most recent study published last January, about 10 to 20%, I think, had a tibial valgus or torsion deformity, which can actually be corrected concurrently with a TPLO. These are images from a paper published previously that shows how you would correct for a medially displaced tibial tuberosity as well as tibial torsion. And it's your standard biradial cut in addition to another osteotomy in the proximal tibia. In this case, the proximal aspect is being lateralized so that tibial tuberosity, which was once medial, is now lateral, and the patella, which was sitting on the medial ridge before, is now sitting centrally. So that also is performed at the same time. And then here's some post-op x-rays of a different case, but similar. So it was a lab as well, so we used an ALDFA of 97. After surgery, we had a 96 degrees ALDFA, so a much straighter limb, closer to normal. These are immediately post-op, the second and third images, and then 8 weeks after surgery, there's good healing present. We also use that wedge as a graft in a lot of cases at the ostectomy site, which you may not be able to see, but is right there. So grossly, that genu valgum deformity, which you can see on a gait exam, is gone. This is a different case, but the same dog as before, who's now walking a lot straighter, didn't have any reluxation. And then the study that was published in January had in-hospital and client questionnaire outcome survey, which showed excellent outcome and a 0 reluxation rate. The complications that were present were the same ones we see with any orthopedic surgery. Infection was present in 1 out of 50 or 2 out of 51 dogs. Implant failure in 1. There was a 66 kilogram Mastiff, and we reoperated on that one, and in addition to a lateral plate, put a cranial plate, and he did great. And then there's persistent lameness occurred in 1 out of 51 dogs as well, and I think that case the plate was a bit too distally and interfered with the patella articulating with the trochlear groove. But the outcome survey showed very satisfied clients. The highest scores were related to the success of surgery and whether they would do the operation again given the option. The lowest ones were stiffness when rising and at the end of the day, which may indicate other disease, hip or stifle arthritis related to the MPL or related to cruciate disease. May indicate early intervention, especially in these complex MPL cases. But in general, there's very good outcome and a reluxation rate that was lower than previously reported. And then lastly, postoperatively, we treat them like any orthopedic surgery. Some will place a soft padded bandage. Generally, we like them to bear weight early. We don't like to keep the stifle in a fixed position for too long. So if you do put one on, 24 to 48 hours is usually sufficient to help with swelling and pain, but not longer than that. Restrictions usually, or activity is restricted for about 6 to 8 weeks until x-rays show good healing. But during that time, we want normal leash walking, just nothing off leash. And then rehabilitation for both the complex and the simple procedures has made a big difference in return to optimal outcome. That should incorporate strength, postural, and flexibility exercises to get them back to normal. That's it. That was like half the time is when I practiced at home. So I'm not sure why. But if you have any questions or want me to clarify anything. Yes, thank you. About the same as a TPLO, if not including the CT. Okay, that's it. I think we're going to take like a 5-minute break, and then Dr. Omlin's going to talk to you about rehabilitation.